in time once they've been fully decontaminated as much as possible.
Right. I think the problem is, how many of you have ever had patients who've taken an organophosphate, say, an intentional exposure? So there's a very characteristic odor, as been pointed out, and it's not subtle. And the problem is that many hospital emergency departments don't have decontamination rooms. Some do, some don't, and sometimes decontamination's set to be outside, which can be problematic. So you can end up, as in this patient, you can shut down the emergency department. So that can be a problem. And then you have your small rooms, then the mask probably, the N95 and the normal masks are not going to block the volatile hydrocarbons. So typically what happens is, as the patient, sometimes they'll get lavage, sometimes they'll just have emesis, and people come in and out of the room having headache, dizziness from the hydrocarbons. So it's a very difficult problem to manage these patients. So the mask will help some, but the mask, the N95 and the simple surgical masks are not going to block the odor and probably not going to block the symptoms people could develop from the solvents. It's almost like huffing, if you will. And so it's important to get the patient cleaned up, get them decontaminated as best as possible, and then also to be on guard that it could very possibly shut down the emergency department. That can be a major problem.
I'll just say a couple of words. I wouldn't have thought that the healthcare workers were particularly at risk from this exposure. And I would have thought it was overkill. The precautions that were suggested in this particular case. I'm sorry, but the malathione. If you're worried about the malathione, it's in the vomitus and it's in probably the diarrheal excretions that this patient has. So universal precautions would be necessary, but the healthcare workers are not going to get sick from this organophosphate. Usually over-the-counter stuff is 3%. He only had 30 cc's or 1 ounce, in the American units. And he hadn't vomited, so I would have thought the risk for organophosphate poisoning from this particular patient were low. And we have to get it clear that the symptoms that are coming from these healthcare workers are because of the hydrocarbon and not because of the organophosphate. And so that the rest of the patients and the healthcare workers aren't at risk, and the emergency department does not need to be evacuated, in my particular opinion, in my personal opinion, because of the smell. And whatever you need to do to alleviate the symptomatology and sometimes it's often imagined symptomatology because it smells so bad that they're getting a bit of a headache, they're feeling dizzy. Those are not true organophosphate symptoms, though. They're more from the foul smell of the hydrocarbon, is my opinion.
And I'd just like to add another thought. Another way to control this and to reduce the exposure to the staff is to make sure that he's intubated, which he probably is going to need anyway, and that you have him on a closed system, so therefore you eliminate any off-gassing of VOCs through the exhaled air. And then when you close the systems also for collecting any vomitus through an NG tube, and you collect the rectal effluent into a rectal bag so that you have everything in a closed system, the smell should rapidly dissipate with a negative airflow. And then you can go to universal precautions, which of course you should use with every patient anyway.
How long would we treat with the atropine and the 2-PAM? What's our end point for treatment then?
Drying of secretions and ease of ventilation.
So at what point were his SATs, 100%, with the tidal volumes adequate, that kind of, and the resistance in the airways, were they not worrisome? When did that happen?
Right.
I would have, treated only until you had, like you said, drying of secretions.
Right. I think there was some reluctance to treat it, and then I think we got into really where there was so much secretions that it took longer to dry up
To dry them, yeah.
some of it. But,
And the
but it
worry
was
about the
very
type of-
dramatic once they started giving the therapeutic doses, that it went from huge amounts of diarrhea to very
Right.
minimal amounts.
And the tachycardia that they were worried about wasn't
Right.
really the endpoint that they should have been worried about.
Right, right, right. How long would you then monitor your patient after the drips are stopped? What is your discharge criteria for this patient, aside from his psychiatric issues?
If you have a significant organophosphate toxicity, your respiratory system is going to show you pretty fast. So I think that you know, assuming that you're going to wean them off, if you're not getting into trouble within a few hours, I think you're safe to transfer them to a psychiatric facility.
And then the last question is, what is intermediate syndrome and how does it present? When do we need to worry about that? Is that part of the hospital stay, post-hospital care? How would you manage that?
I guess so. Well, the intermediate syndrome occurs several days to weeks after the exposure. It's primarily a neurological syndrome, and with weakness and such. And that's how you would expect to find it. They would have weakness of muscles. Some of the people that do the massive ingestions, I don't know if anybody was at that lecture where they were talking about pressing the heads down in the beds in the hospital in, I think it's Sri Lanka. Well, most of our people don't get that impressive a syndrome as they do, but we don't have as much organophosphate exposure as they do as well.
Well, I guess I might be a little more conservative and all this depends on if we're talking about this particular patient as patients in general, because obviously but in general, you probably want to watch them, depending on if they were a severe exposure, you're probably going to want to monitor them for at least 24 to 48 hours post stopping therapy. So there have been cases where people redevelop symptoms, and with the intermediate syndrome. So somewhere in that time frame, one wants to be clear that everything has settled down and that the atropine and the 2-PAM have got the patient under control. Remembering too that some of the organophosphates are extremely fat soluble, and they can be leached out of the tissues and cause return of symptoms. So, and although the intermediate syndrome may be a totally different mechanism, but I think so in summary, it would depend on the amount of organophosphate the patient ingested. If it was a relatively trivial amount and a very small amount of atropine was needed to dry the secretions and get the lungs clear, then one might be able to watch them for a shorter period of time. If it was a large volume intentional overdose, they're probably going to be in the ICU anyway for several days. And then I would recommend to watch them for at least 24 to 48 hours after all the antidotal therapy had been discontinued.
I would agree with Dr. Bronstein. I think that this, a half-life of atropine is about 2 hours, and at least you want 5 half-lives before the atropine is all gone and you're not seeing recurrence of symptomatology. So I'd say at least 24 hours, and it could also depend on the particular organophosphate. This patient took malathion, which isn't particularly fat soluble or hasn't got a delayed onset of symptomatology, but you'd have to look at the particular organophosphate as well to see whether they were one of the ones that could be leached out for, hours to days afterwards.
Thank you to our expert panel, and thank you, audience, for your participation as well. Yes?
Sorry, do you mind if I just have a few comments? Is that all right?
Sure.
So I missed the case at the beginning. I'm sorry I came in late. My name's Darren Roberts from Australia, but I've done previous work in Sri Lanka. And a lot of these issues that were being raised and discussed, I think, are very important and things that we see a lot of in Australia also, so my experience in Sri Lanka was always very interesting. In terms of the first point, we've had this as a major issue in Australia in terms of inappropriate management of patients, this whole fear of secondary contamination, where patients have been nursed outside in the receiving bay and have really been deprived of care that they need. Particularly with malathion, we know that it's very poorly absorbed through the skin. If it does happen, it happens over a number of hours and you need a fairly large exposure. When I was working in Sri Lanka, I was exposed to a number of OPs through vomitus or other excretions, and I never got sick. And most of the people who I worked with never got sick. We actually wrote a letter in QJM a few years ago just sort of describing our experiences to give safety. So in Australia, we developed a consensus guidelines, which is now used through all the hospitals. So there's something written down to sort of say to staff, exactly what's been discussed up here, I think, that the chances of getting poison from an OP is very low. What you're smelling is a solvent, and regular rotation of staff can decrease any problems with that. In terms of how long to treat with atropine and 2-PAM, particularly with malathion, because it's fairly short-acting, you can see an increase in the butyrylcholinesterase. And once you start to see recovery of that, that can be a biochemical marker that tells you that they're better. But otherwise, I think in terms of those clinical outcomes of monitoring for secretions and sweating is useful. The intermediate syndrome, I think in particular, the thing to remember is that often that comes on when it does come on after the cholinergic crisis has gone away. So often they're often on a smaller dose of atropine at the time when it happens. And there can be delays. Once a person gets up and starts to mobilise, that seems to be a thing that may precipitate them to go into IMS if they had a much smaller exposure. So I think 24 to 48 hours would be appropriate monitoring. And spirometry can be a useful test to monitor for that.
Can I just make one comment about the butyrylcholinesterase? It's available in the province where I work in about 2 weeks' time. So it's not a clinical marker that we can use.
Which is a shame because it's such a cheap and very easy to perform assay. But either way, I don't think you need it to monitor. I think clinical endpoints is a more important thing.
Hi, I'm Trinh Nguyen from Vietnam. Firstly, thank you for the presentation, and I'm really interested in the question here because also the question we have to face when we meet any patient with organophosphate poisoning, and the way we do the atropine in Vietnam is rather different. We got very severe patient with organophosphate poisoning with the cholinergic syndrome, and the way we do with atropines E, we do not use the atropine infusion anymore. Now we ask ourselves what is the first dose of atropine, how long we have to repeat the atropine, and when to stop it. And for the first question, we can bolus